the mind of the treating physician, how sick is the child, would mean the severity of the bronchial asthma, which drug should be used for the treatment, what are the optimum doses and the delivery route, when is more aggressive management is necessary, should the child be admitted, and what are the value of the ancillary testing like chest X-ray, blood gas. So the SINA guideline trying to answer all those questions, which usually an essential to initial management and treatment of acute bronchial asthma. We know the treatment of the bronchial asthma, it depends on the severity of exacerbation. And the assessment of the bronchial asthma exacerbation is continuous process with two different stages. The first is the static assessment to determine the severity of the asthma and initiate the appropriate treatment according to the SINA guideline. And the second, the frequent assessment to evaluate the response of the treatment. The SINA guideline adopted the BRAM score, and Dr. Sami, he elaborated a little bit on the BRAM score, and which is has been found to be feasible, valid, reliable tool to determine the acute asthma severity in children aged between 2 and 17 years of age. And the clinical pathway based on the BRAM in the pediatric emergency showed the decrease the length of stay in the pediatric emergency, decrease the bronchodilator use, no adverse outcome, or increase acute care encounter. This is the BRAM score, which based on the 12-point score, and mainly we take the AutoSat, suprasternal retraction, scalene muscle contraction, air entry, and wheezing. The severity classification based on the BRAM also is associated with the risk of hospitalization. If the mild, it's between 0 and 3, the risk of hospitalization is less than 10%. Moderate, the risk of hospitalization is 10 to 50, and severe, the risk of hospitalization is the 50%. We know that after the assessment and utilizing appropriate assessment tools, which here in the SINA guideline, we choose the BRAM. There is a 3 major goal of therapy for the pediatric asthma patient in the emergency. One is the rapid reversal of the airflow obstruction, correction of hypoxemia or severe hypercapnia, and reduction of likelihood of recurrence by ensuring adequate baseline controller therapy when indicated. Now we'll go quickly, we elaborate more on the drug we are using in our guideline, SINA 2021. We know most of the children who came to the emergency, they are hypoxic. And we know the hypoxia is the primary cause of death from the exacerbation. Supplement of the oxygen, it will help to decrease dyspnea, aid the bronchodilator, and support myocardium and decrease the risk of the arrhythmia. So we recommend to start humidified oxygen to maintain AutoSat more than 92%. All nebulized medication should also be delivered with oxygen generally at a flow rate of 6 to 8 liters per minute. The second drug, which is the mainstay treatment of the bronchial asthma, and it's the beta-2 agonist bronchodilator. And Dr. Sami, he elaborate which route we are going to use. We have the nebulizer or the MDI in the pediatric emergency. The literature showing that in the mild bronchial asthma, administration of beta-2 agonist by MDI is at least as effective and possible superior to the delivery of medication by nebulization. No significant difference in the hospital admission rate. Length of stay is almost shorter by 30% when we are using the MDI compared to nebulizer. and the side effect, tremor and tachycardia, were lower in the spacer. And it's very important right now in the pandemic, COVID pandemic era, to utilize the MDI in case of mild to moderate bronchial asthma. Another question is the continuous versus intermittent nebulization. All the literature showing there is no difference between the continuous compared to the intermittent nebulization in form of the outcome and the side effect. We recommend continuous therapy suggested over intermittent nebulization or MDI therapy for children with moderate to severe exacerbation. Another drug commonly used in bronchial asthma is anticholinergic agent or ipratropium bromide. The literature is showing the benefit and the add value adjunct and synergistic therapy for ipratropium bromide or anticholinergic if added to the first 3 doses of Ventolin nebulization. And there is a 20 randomized trial comparing combined inhaled beta-2 agonist and anticholinergic with inhaled beta agonist alone. Combination therapy reduced the risk of hospitalization. The incidence of nausea, tremor was lower in the combination therapy group, but there was no significant difference in the rate of the vomiting. Systemic steroid, we know we are utilizing the systemic steroid in acute exacerbation for 2 reasons. One, as an anti-inflammatory drug. Second, and it will help to upregulate the airway beta receptor, which add a synergistic and increase the sensitivity of beta-2 receptor to the Ventolin. And all the literature showing that the meta-analysis, systemic review, and prospective, it reduces likelihood of the admission and decrease time to clinical improvement and discharge. Dexamethasone versus prednisolone, a meta-analysis comparing a 3 to 5 days course of oral prednisolone or prednisone with dexamethasone. Treatment were equivalent regarding the rate of relapse and unplanned hospitalization, which those the 2 common steroids we are using in acute exacerbation of bronchial asthma. Another drug used in moderate to severe bronchial asthma is the magnesium sulfate, and it's a common drug used in a pediatric ER, and there is a well evidence that using the intravenous magnesium sulfate demonstrate benefit, improve the pulmonary function or a clinical asthma score in children who had failed to respond to conventional therapy. Another intravenous terbutaline, which is the last drug we are using in case of severe bronchial asthma, that not responding to conventional therapy or magnesium sulfate. And there is a systemic review of a study published through the September 2012, found only 2 randomized trials that met inclusion criteria. And the outcome of that randomized control trial, there is a shorter recovery time and improved pulmonary score index. So now we'll move to algorithm, which published by SINA group, and it's a quick aid and standardize of the treatment for any pediatric emergency physician, which help to standardize the bronchial asthma management among the pediatric emergency. And this is the 1 page containing all the algorithm for mild, moderate, and severe asthma exacerbation. In case of mild, which means BRAM between 1 to 3, when we encounter a patient with mild bronchial asthma, usually vital sign initially, and at the discharge, we recommend to keep SAT more than 92. Initial salbutamol, reassess. If no response, we'll continue salbutamol Q20 minutes for 2 doses. Consider adding ipratropium bromide and oral steroid, then reassess BRAM after 1 hour. So what I would like to mention here, if the patient already he received his MDI at home, that's indicating is he required the 3 doses back-to-back with ipratropium and steroid. The other important issue is monitoring and continuous monitoring in the emergency, and we recommend the monitoring to be Q20 hour, Q20 minutes to see the response for the treatment. Then we are upgrade or downgrade our treatment according to the BRAM score. If there is a good response to the BRAM score initially, still is mild, we are going to discharge him on the salbutamol PRN. If the child given a steroid, we are going to complete the course of a steroid, inhaled steroid if indicated, and the most important, we need to provide action plan and asthma education. And there is a good bunch of literature showing that there is a correlation between the frequent of ER visit for bronchial asthma patient in the pediatric and the knowledge of parent about the asthma management and using a new technique. In NGHA, we showed the significant drop in the revisit after we assign an asthma educator in the emergency to educate the family about the proper use of the medication. So we encourage the asthma educator or the physician, he need to educate the parent prior to the discharge. We back if after the initial 3 doses, the BRAM score is increasing. If the BRAM score 4 to 7, we are going to the moderate pathway. If a BRAM between 8 to 12, that indicating we are going to the severe pathway. Moderate pathway, moderate BRAM, if the child in a moderate bronchial asthma exacerbation. As initial, we need the vital sign, keep SAT more than 92. We are giving 3 doses, which Q20 minute salbutamol and ipratropium bromide. We start systemic steroid after the bronchodilator, and we reassess BRAM after 1 hour. The systemic steroid, no benefit for giving intramuscular or IV comparing to the oral steroid. The efficacy, it's the same. So we prefer if the child can be tolerate oral to give dexamethasone or prednisolone. After 1 hour, if the BRAM is dropping to mild, 1 to 3, that indicating is responding very well to treatment. We observe for 1 hour in our emergency after the last bronchodilator. If the BRAM continue to be or equal less than 3, we are going to send him home on salbutamol Q4 to 6 hour for 24 hour, then BRN, inhaled steroid till the next clinic visit. We'll complete the oral steroid course. Again, we need to educate and provide action plan with the secure clinic visit within 1 week. If the BRAM is
5 minutes, Dr. Abdullah.
Okay. If the BRAM is not improving, we'll go to the severe bronchial asthma. which indicating the child PRAM score between 8 and 12. Again, the 3 doses of Ventolin and ipratropium bromide steroid keeps at more than 94. If improving to mild, will go to the algorithm of mild. If moderate, will give another 3 doses of Q30 minute of salbutamol. If improving, will discharge him after observation 1 hour. In case of the severe not improving, then we go to the second line of the therapy, which in that indicating he required IV access fluid, continuous salbutamol infusion, consider IV salbutamol, and monitor electrolyte, and he required admission with the consultation with the PICU. Quick, the arterial blood gas, it's rarely necessary in pediatric emergency. It doesn't add any value to judge the clinical course or the treatment, doesn't guide me through the treatment of the bronchial asthma. And usually it's required in severe bronchial asthma and when there is a required for ICU admission. Chest radiograph, there is a certain indication. It's not routinely done in the bronchial asthma exacerbation. If you suspect pneumonia in the presence of vocal examination finding, fever, severe disease, uncertainty about the diagnosis, and if you suspect a complication of a bronchial asthma, you're required to do chest X-ray. The last message, we are trying to avoid intubation in a pediatric emergency because it will worsen the scenario, and there is, we are trying a non-positive, non-invasive positive ventilation before intubation, because whenever you intubate a child with a bronchial asthma, you are asking for the complication to happen. And the indication of the intubation is a clinical indication. It's not based on the arterial blood gas. The indication, if there is a hypoxia, despite provision of the high concentration of oxygen or non-invasive positive pressure ventilation, severe and unremitting increased work of breathing, inability to speak, altered mental status, and respiratory or cardiac arrest. Finally, and I think it's an easy evidence-based guideline provided by SINA, and easy to apply and follow, and it's improved the outcome of the pediatric patient who present with acute exacerbation, and also the most important is standardize the treatment among the pediatric emergency. Thank you.
Thank you, Dr. Abdullah. We have some questions actually. In case of moderate to